walk us through a clinical case for better clarity. So please join me in welcoming Dr. Christina Franz as she takes over. Please give her some patience.
So I'm back again. I missed you all, so I couldn't be without you this afternoon, so I'm here. We are going to speak at this first part of the class about insomnia. So, does anyone know what is the definition of insomnia? Um, just let me take the pointer here. So, we are not talking about the insomnia symptoms that all of us will experience during our lives. We are now talking about the insomnia disorder. And to be classified as a disorder, the patient must have a difficulty initiation sleep or present a difficulty maintaining sleep. That means that he cannot sleep during the night or has multiple awakenings, sleep fragmentation, or waking up earlier than desired. So this patient will tell you that he has no problem with going to sleep, but he wakes up at 3 or 4 o'clock in the morning and cannot make sleep again. There is a resistance to go to bed on an appropriate schedule, and this difficulty of sleeping without parent or caregiver intervention. But to be classified as insomnia disorder, there must be present a daytime repercussion. And often, patients report fatigue, lack of concentration or memory impairment. There is impaired social, familial, or academic performance. There is mood disturbances. Daytime sleepiness can be present, and also behavioral problems such as hyperactivity, impulsivity, aggression, reduced motivation, proneness to errors, or concerns about dissatisfaction to sleep. So the main thing about insomnia is there must be present a daytime dysfunction, okay? In spite of all that, the patient needs to have an adequate opportunity to sleep to be classified as insomnia. He needs to have opportunity, time, and a place to rest. Insomnia is a disorder when it happens at least 3 times per week during at least 3 months. Okay? Insomnia is clinically diagnosed. So the physician is the one that makes the diagnosis. And there is no objective examinations that will lead to insomnia disorder. So it's a clinical diagnosis. If the patient have all these and no other cause was determined, then insomnia disorder is diagnosed. And how it is? We have here some prevalence of insomnia diagnosis. In Brazil, it's about 15% of the population has been diagnosed with insomnia. Of these 15%, 32% are women. So women are more prone to insomnia. So I tried to look at the data from India, of course, to bring this to you. And what I found is that in South India, about 19% has insomnia of the population. People with chronic physical illness, about 28%. It's too much. About 11% in healthy persons in your country has insomnia disorder. I don't know how to pronounce this, Bangalore, but 1/3 of the population of, is this a city or a state? Okay, so 1/3 of this metropolitan city has insomnia disorder, and 27% of these didn't know that they have it. So they live with this sleep problem and doesn't even know that this is a problem. Of that, 15.1% healthy patients, 32% in patients with other disease, and overall about 26%. So it's a lot. And this is mainly because of our lifestyles nowadays. What are the risk factors then? We have the postmenopausal stage. Oh, this is a huge thing. The postmenopausal stage increases the risk for many sleep disorders, but exclusively for insomnia and sleep apnea, phobia. As we age, we have more. That's okay. That's okay. Thank you. As we age, we have more chance to develop insomnia. Mood disturbances are also very related to insomnia. And having someone in the family who presents with insomnia is also a risk factor. Having also a previous personal history of insomnia is a risk factor, and of course, shift work. And there are others. I brought here a video. I don't know if you are going to be able to listen. Maybe. Let's try. Sound is not on. Can someone just give me a little help here? Is it possible for them to listen to the sound? No? Okay, then no video. I can send this video for you later. It's from TED Talk. It's just 4-minute video. Okay, so we have a 3P model for insomnia. This 3P is related to the predisposing factors. First, predisposing factors. We have biopsychosocial characteristics that are genetically predisposed or perhaps have a biological disposition toward being a hyper-arousal person that will contribute to the difficulty of falling asleep, staying asleep, or waking up too early. The other P stands for precipitating factors that are stress events that goes on in our life. So an event or a situation that causes a bad night or lots of bad nights of sleep, like a party, an exam, unemployment, and other things. And the third P stands out for the perpetuating factors. Those are the bad habits that sometimes we doesn't even know that we have them, like sleeping in, napping, developing wrong sleep associations, as we talked this morning, with being awake or being in the bedroom and things like that. So I gave you this first lecture this morning, and then I went to my room because I had some work to do. And I was feeling so sleepy. Because for me, exactly now is 6 a.m. So you can imagine how is my body temperature, how is my cortisol, and I just had lunch. So everything is so strange. And I was falling asleep, working in the computer, and falling asleep. And I said, oh, I'm going to take a nap. I said, no, I can't. I had a cup of coffee, put on my light glasses, and tried to manage to stay awake. Otherwise, I wanted badly to go to sleep, but otherwise, I will not be able to sleep during the night. So sometimes we need to know those things to make them happen properly. I would love to have taken a nap. I should be napping by now, until now, right? So if you see this hypnogram, okay, just look at the first one. What we see here is this is wake, okay? In Portuguese, vigilant, wake, stage N1, stage N2, slow wave sleep, and REM sleep stage. Here it's shown in a different manner. But what we see here is the time, 23:57 until 6:57 in the morning. What kind of insomnia does this first patient present here? Is it insomnia of the beginning of sleep, maintenance insomnia, or early awakening? Beginning. Why? Perfect. At what time did this patient manage to sleep? Yeah, about 2:45 in the morning. So the subject was in bed, trying to sleep, didn't sleep, and then he slept. Okay, so this is, just let me show you here again. So remember this, the difficulty in initiating sleep. Okay, so we have these three types of insomnia: initiating sleep, maintaining sleep, and waking up very early. Just a second, please. Okay. Now, let's have a look at this second type of hypnogram. Suppose that the patient comes with this hypnogram. What you see here. Perfect. Okay. You are already sleep physiotherapists. This is maintenance insomnia. How do I know that? Because the subject didn't take long to sleep and slept okay, pretty well at the first half of the night and then woke up at 4 a.m. He couldn't get back to sleep until 6 a.m. when he slept again. And the final one, now it's easy, isn't it? And the final one, yeah, it woke up at 3:57 in the morning and couldn't get back to sleep. Perfect, very easy, understandable, right? Yes. But the patients come with all of them, or with many different combinations of these three. And then this is the great thing. You already saw with Julia the questionnaires this morning. So what kind of questionnaires, if a patient is standing in front of me and I suspect that this patient has insomnia, what kind of questionnaires can I apply? Insomnia Severity Index. Perfect. PSPY? Yeah, perfect. You can do that too. But the most widely used is Insomnia Severity Index. And you have also the classification of that. Okay, so the patient enters your office and tells you or have a sleep diary of 10 days. and you suspect of insomnia, what do? You do the questionnaire. Okay, then you have a clinically insomnia. What do you do next? Perfect. See, you already sleep physiotherapist. You send them to the physician. The physician will diagnose and send back to you. When you send them to the physician, please do a report. Write down everything that you see. Put your brand in there. Put your name, your affiliation, your credentials, your phone number, your WhatsApp number, everything. So this is the way you are going to show to others that you are a professional and that we can send you more patients. Okay? The first steps are hard, but then they will know you and you become a reference. Ones will become a reference on sleep cognition. Others will become a reference on sleep in women. Others will like pediatrician. And we all live together and happy. Okay, then the patient comes back to you with a letter from the doctor asking first, before of course, the doctor thinks about medication. But good doctors know that insomnia is not treatable by medication. Yes, we do treat insomnia with medication because it's easier, it's faster. Sometimes the insurance covers the cost of the medication. But the first non-pharmacological treatment is cognitive behavior therapy for insomnia. So, behavioral and psychological treatment for insomnia must be addressed prior to any kind of medication. That's why I said to you that a good physician will know this. And if the physician doesn't know, you can tell him, because maybe he's not into sleep medicine. And you can tell him, oh, doctor, I completely agree with you, but what about trying CBTI first? What about trying one of these non-pharmacological strategies first? And maybe you can combine them. We can have the medication combined with the non-pharmacological approach. And maybe the patient will really need only the medication because it's a patient that doesn't follow it's that patient with that room that we saw in the morning, that very stubborn room, remember? So maybe patient doesn't comply with what we want them to. But what we have here is that cognitive behavior therapy is the first line, the gold standard treatment for insomnia. And in a recent investigation by a Brazilian group, this is Dr. Drager. He was until last year the president of the Brazilian Sleep Association. And they took a comprehensive review to see what kind of CBTI would benefit patients the most. Okay, and they didn't have any answer. So for now, any kind of CBTI, in person, online, group, through an app, okay, will benefit the patients. We also have some other alternative treatments like acupuncture, aromatherapy, biofeedback, massage, meditative and mind-body practice, and physical exercises. But there is no consensus in the literature about them. We do have some evidence, but not enough to draw a systematic review, a meta-analysis, okay? So what we do, we work with what we have. And then I call you all to make more research about this topic, because we need to. So I'll have a briefly look at the CBTI with you. CBTI in Brazil is performed by psychologists. So this is a specialization for them. So I do have some patients that I need a psychologist to work with me. So psychology will go through all these steps that I'm going to show you. So CBTI is the gold standard treatment for insomnia. This is specifically for insomnia. They have about 4 to 8 weekly sessions, but could stand longer. I have patients going on this for 1 year. There is a daily homework. You have to change your habits. So every day you need a motivational step to change it. It can be tracked by sleep diaries and other experiments or through other reports. Patients can record an audio or WhatsApp or something. And what are the CBTI components? Sleep hygiene, stimulus control, sleep restriction, cognitive restructuring, and relaxation or some kind of mindfulness. What we are doing now is we are going to go through each one of these. Perfect? But basic premises, the first step is do not track your sleep or do not worry. You say to the patient, do not worry about your sleep. Avoid compensating, just like I told you now. Avoid daytime naps. Avoid caffeine. Avoid electronics because of the blue light. And no caffeine about 3 or 4 in the afternoon. I have a coffee machine in my office, and my patients, when they come in the afternoon, they already know that after 3 p.m. the machine is closed. No one drinks coffee. There's only water. And then sometimes they ask, "How can I have a coffee?" No. And they don't have. I don't give them coffee after 3 p.m. Some people have the receptors that we call that will make them drink the caffeine, coffee, and will make them alert. But some people don't. My dad, for example, he drinks coffee at the time he's going to bed, brush the teeth, and sleeps. So I say to him, your receptor doesn't work well. That's okay. You're an outlier, okay? So I don't mind about him, but I do mind about my patients because it can interfere. Because the receptor in the brain that the caffeine that is adenosine, it competes with the caffeine that comes through the receptor. So if I have lots of coffee, this receptor will be blocked. And the adenosine, that is the hormone for being tired all day long, will not be there. So the patient, instead of go to sleep, is going to be tired because of the stimulation. And the sleep hygiene. So I have lots of reading things here. I kindly ask you, if you want to take pictures, I can send this to you later. But the idea is to give you material to study later. Of course, I cannot explain the world of the sleep physiotherapist in insomnia in 1 hour. So there will be lots of homework for you. But it's good because we learn when we repeat things, when we read, and I think you're going to be okay. But these sleep hygiene rules are a set of changes in habits that we talked about. So change in environmental conditions, change in the setting, in physiological elements, in behaviors that cause this poor sleep. And we have to intensify the sleep promoting behaviors. So we have a rule of a set of rules of sleep hygiene. Turn off your electronics. Don't perform vigorous exercise before bedtime. Avoid spicy food 3 hours before bedtime. And there's a lot of things. You will have an article that we published explaining details of each one of them, okay? So you can understand the rationale behind each one of them to explain to your patients. It doesn't mean that in a physiotherapy session you have to explain everything to your patient. You just explain the ones you think are important for now. Otherwise, your PT consultation will last a day. Sometimes I spend 3 hours with one patient. It's exhausting, but sometimes they need to. And I prefer to spend these 3 hours first and have something changing in his mind than having the common thing that we have in Brazil, just like 1 hour I attend one patient, so I have one patient each hour, you see, so it's different. So this is the sleep hygiene recommendations. I know, again, it's too small, and again, I'm not going to go through all of these, but just to explain to you that in the Brazilian sleep consensus that I spoke about this morning, these are two friends of mine that collaborated with me, and they are insomnia expertises. And I told them I want the rationale behind each of these sleep hygiene recommendations to be easy for everyone to understand. So we tell the patients to have a routine, to use the bed only for sleep. If they have difficulty returning to sleep, they have to get up, take a walk, do something really boring, and try to sleep again. Why? I asked them to do something really boring. Because if I let them do whatever they want, they will get the cell phone and then sleep is gone. Or they will watch a movie and be happy or sad because of that movie, start thinking. So they will lose their attention in what they need. So I tell my patients, walk around your house a little bit, do something really, really boring. Stay still. Stay still. And then when you feel, go to bed. Sleep doesn't come, walk and stay still. Watch something, watch a flower, watch the floor, do something really boring. So this is not going to last forever. This is just a way to train again your brain that condition behavior that we spoke this morning about associating the bed and the bedroom with sleep. So we have to do that in little steps. It's really, really difficult. It's very easy to say, but it's really difficult in clinical practice. The pre-sleep routine is also very important. Physical activity during the day is very, very important, but maybe some activities at the evening could be better, could help with sleep. For example, inside a warming pool, or some breathing techniques and relaxation, they are fine. I had a patient once, and she had insomnia, and I told her to do some exercises, and 3 months later she came, and she was happy and talking a lot, and she had lose some weight, and she said, I'm better, but my sleep didn't change. But I started doing what you asked me. I'm going to beach tennis 4 times a week. I said, oh, perfect, gorgeous, but at what time you do it? I do it 9 o'clock in the night. I said, okay, perfect, do you like it? Yeah, I love it. Okay, I do it with my friends, Everyone is there all the time. We have beer later. We have loud music that I love playing with loud music. And I also had artificial lights. I said, perfect thing not to do. Let's shadow. So you see, we have all those little things that were impacting her sleep. So what I said, try to put these in the morning. Okay? So it's not the physical activity that was interfering. It's the other things in this context that were interfering. So we have to talk about them, go through these things. The avoiding of stimulants and avoiding the naps. Patients also ask me, can I nap? How long can I nap? At what time can I nap? So this is a question for you. At what time I am supposed to nap that you think is not going to interfere with my nighttime sleep? Just after lunch? After lunch is the perfect time for napping because we have a drop in central temperature. And we need that temperature low in the lowest, in the nadir that we call true sleep. But this nap after lunch can last about 2 hours. No way. It can last about 20 to 30 minutes. There is no consensus in the literature, but we recommend around 20 to 30 minutes, so the patient will have at least one part of the sleep cycle. So I tell the patients not to nap. It's just like caffeine, it's just like coffee after 3 p.m. Okay? Because these will interfere in their sleep. But again, it depends so much on their routine, what time they wake up, what time they go to bed. So there is no right answer. It depends on the patient. And each of the patient is one. Each of them has a history. And we must know this to help them. Well, light is another thing, just like this female beach tennis player that I told you that can interfere a lot with sleep. In fact, light is the main entrainment factor that we have. The environment, just like we spoke, and the eating is also something that can interfere with sleep. So I invite you all to read this chapter later. This is in the material, okay? And how is the stimulus control therapy? So let's talk about each one of them. Stimulus control is telling the patient to pair stimulus bed with the response to sleep. So the bed is only for sleeping, and the sleeping is only for the bed. No sleeping in the couch, no sleeping while seated, no sleeping in the car. So this is a conditional thing that we must teach our brains. Avoid being awake in the bed for more than 30 minutes. So wake up, do something boring, and get to the bed again. And no electronics. So what we are doing, we are controlling the stimuli that we have. Okay? This is based on principles of psychology operant conditioning. It's very linked to perpetuating factor of sleep. And what we have to do is to remove sleep-related triggers and establish an appropriate sleep-wake rhythm. Okay? So, do you think it's easier to establish a morning rise time or a night time to go to sleep? Morning rise time. Imagine that you go to your home tonight and say, I'm going to sleep at 8 o'clock. Can you just shut down and sleep? You can't. But if your alarm clock rings, you wake up. So this is one tip for you that I've seen in practice. If you want to change the routine of your patients, start that by changing the time that they wake. At the beginning, it will be very hard, but they will get used to it with the time. Don't change the time that they go to bed, because you can create negative conditioning, negative associations. There is um, other item on CBTI, that is the sleep restriction. That means that you are only in bed for the number of hours that you actually are sleeping. You need to have a consistent bedtime. You need to avoid sleeping longer in the weekends or holidays. Avoid daytime sleep at all. Decrease time in bed and increase sleep efficiency. We want that metrics to be above 85%, just like we spoke this morning. I'm going to speak again in the next slide. And in adults, the time in bed is sleeping more than 30 minutes and gradually titrating this up. Let's understand this better. So the sleep restriction therapy limits the time in bed to the average number of hours spent sleeping. The aim is to improve this sleep efficiency. So let's have a look later on. I thought the slide were here. We'll have a look on that sleep restriction thing in a few slides. Just hang on to that. The other component of the CBTI is cognitive restructuring. This is harder for us to approach. So here, maybe I do need the psychologist. So the patient tells you, I've tried everything. This won't help my sleep. All these things that you're telling me, it won't help. I've tried everything. I've been to every place. I've been to the best doctors in the world. No one changed my sleep. This happens a lot. So if the patient has unhelpful expectations with his life, we as physiotherapists cannot do anything. We need a psychologist. And I have a really hard patient right now exactly about this. She's been my patient for 3 years. She doesn't accept a word that I say. I just sent her to the psychologist. She went once. She's not going any longer. So before I come here, I called her physician and I gave a huge report saying everything, specifying everything that I have tried in the last 3 years. And I'm sorry, but physiotherapy is not helping this patient any longer. And this patient needs to sleep. So please, if you think it's appropriate, can you please conduct treatment? I mean, please give her a medication. And I'm not sure she will take it. So the problem is bigger than we can handle. And this is very sad for us. Many of my students call me and say, Chris, what I do? I said, you cannot do anything. And we have to accept that. So I tell you happy stories, good stories, stories that work. But most of them don't work either. It's part of our routine. Sometimes you try to rehabilitate a stroke patient and It doesn't get better, but it doesn't get worse. So this is good. So we have to see it through the eyes of the physiotherapy. Okay. Uh, the patient say, I got insomnia for my grandfather. There's nothing I can do. It's a family thing. It's very common. So they have these misconceptions about the causes. They say, I'm going to fail the test if I don't sleep well. I'm going to fail in my life. I will be no one if I... So they have distorted perception of these consequences of insomnia. And they also think that if I take a nap after school, I will help my sleep. So they take a 3-hour nap. And then they go to sleep at 4 in the morning. And then, besides insomnia, this patient might be predisposing a circadian rhythm sleep disorder. And then the thing gets really, really hard for us to disentangle it. So, we have all these things here, the cognitive and emotional restructuring that is the psychologist technique. So the principle is a cognitive triad. How we think affects how we feel and what we do. So affects the whole thing. And we also have this relaxation and mindfulness that helps a lot. Relaxation, progressive muscle relaxation, calming imagery, mindfulness, focus on the present, focus on your achievement. One day, each day, one day, go through small steps, set small steps that your patient can achieve. Don't set a huge step. Okay, you have to sleep 8 hours with no fragmentation. It doesn't exist. If you sleep 2 hours and feel good, that's good. Then the next week, 2 hours and a half. Set small limits. Set small goals. Well, you know more than me about mindful and things like that. I look forward to learn with you all. But this helps a lot because this controls anxiety. And anxiety has everything to do with sleep and with hypervigilance and with cortisol, okay? And there's also calming apps. They can listen to music. I have a friend in Brazil who works with meditation, and he recorded some nice words. He's a very handsome guy, so he has lots of followers in the social media. So we recorded some nice words of calming imagery and calming words that sometimes I give the patients to listen before they go to sleep. And there is, yes, there are evidence on that, okay, that this works. But with a small sample size, that thing that we all go through. So the relaxation therapy is to reduce the sleep-related performance anxiety and bedtime arousal. We have digital therapeutics apps available. So we have Knox, Hello Better, Big Health, Smooth, Somnios, with Way, Well Time. We have all of them. In Brazil, we have one that I didn't put here. I tried to work with one of these apps, I think 5 years ago, something. But I was going too much into the psychological thing, so I quit. Because this is something that you have to pay each month. So I quit, and I tell my patients, I refer them to a psychologist. Well, here we come to something that I love, that is physical exercise as a therapeutic approach for adults with insomnia disorder. So this was the PhD of my friend Carol, and what we saw here is that when the participants had been physically active, this was meta-analysis, and we looked into many, I don't remember how many, but many studies in the literature. And we saw that when insomnia severity index, Athens insomnia scale, and the PSQI, that is not an insomnia questionnaire, but is a sleep quality questionnaire, we have good outcome in these measurements, but we have no change in objective measures. So besides the low quality of the investigations, that we had a lot of bias, small sample sizes, what we saw in this meta-analysis is exactly the main feature of insomnia, that is this mismatch perception between the subjective and the objective measures. So in research, we sometimes see a polysomnography of a patient with insomnia, and we don't see any change in the polysomnography. Everything is okay. And you say, how come this patient has insomnia and everything is okay in the polysomnography? Polysomnography is not used in insomnia patients, except if you want to rule out any other sleep disorders, such as sleep apnea, for example. But in research, we do it exactly to rule out other sleep disorders. And how come we have a very different objective measure and the clinical complaint of the patient? And sometimes I look at, is it the same person? Am I talking about the same thing? Yes, it is. And why this happens? Because sometimes the patient have what we know as sleep misperception. He sleeps, or he or she sleeps, but doesn't feel rested, doesn't feel that sleep. Okay? It is also called subjective insomnia or paradoxal insomnia. And if we had physical exercise showed to us a subjective improvement in all these scales, so we thought that this subjective improvement is a very good outcome. So in the insomnia severity index, we had a moderate effect favoring exercise. So exercise is a good treatment, and we had a strong effect favoring exercise regarding sleep quality. Okay. Yeah, but what kind of exercise? What's the intensity of exercise? How long should I perform the exercise? What time of the day should I perform the exercise? And for how long? We don't know, because these things change so much. So if you take aerobic exercise and Tai Chi Chuan, it's completely different. Both are exercises, but they are different. So we don't have the answer to these questions. What we know is that this type of therapeutical physical exercise can be considered in the treatment of insomnia. Aerobic, resistance and muscle strength, stretching, yoga, Tai Chi Chuan, being physically active matters. Walking, dancing, cycling, going up and down in the stairs, and we have to consider the type of exercise and the environment, just like I told you, if indoors or outdoors. The intensity needs to be moderate to intense. Mild doesn't work. The duration, we know that the minimum of 50 minutes 3 times a week as per recommendations. The time of the day, it doesn't matter because it depends on what kind of exercise you're making, what kind of exercise you perform. And the length, minimum of 2 months to start to see any improvements. You sleepy? You're all minimum of 2 months for subjective improvement. But we will see greatest improvements 4 months on. So you know how difficult it is to make the patient stay with us more than 4 months. So exercise interventions may be useful as adjunct therapies with CBTI, okay? Now we have briefly 2 clinical cases. First one, this is from the Meyer Krieger's book, The Case of the Woman Who Refused to Sleep. Okay, can someone read that loud for me? Someone in that middle, please read that loud for me. You.
Situation of insomnia. The women was thin and nervous. She told me it usually took 3 hours or 4 hours to fall asleep. And once she did, she would wake up after an hour and be unable to sleep again. She had no other medical condition at that moment. She told me that she remembered the exact night it started, over 20 years earlier.
What do you think about it? Think this is the patient in your office. It's sitting right in front of you. What would you say to her? What in this speech, what gets your attention? Perfect. She knows exactly the night it started. This means that something happened. And this something is the cause of her insomnia. So we have to treat insomnia or this something? This something, okay. So she developed a fear of falling asleep after her son got killed in front of her in the same apartment. And she tried to stay awake for as long as possible to avoid someone to get into the bed. So she was hyper vigilant all the time. And of course, she had to see a psychiatric, and insomnia can be secondary to other disorders. Okay, this is fictitious from a book. Now, a real case. So, a patient came to me, a 25-7-year-old woman at postmenopause, referring sleepiness, and she said she wished to take a nap or could sleep anytime, and she was referred to me by a gynecologist. She said she went to bed at 11 o'clock and wakes up spontaneously at 7 o'clock. This is another question that I make to my patients. Do you wake up with the alarm clock or spontaneously? Because this is different, okay? She told me that she took longer to get to sleep. She woke up several times during the night. And she felt that she could not relax. Any noise would disturb her. She drinks water during the night. She has a bottle of water beside her bed. Terrible habit. And when she has no sleep during the night, she starts doing household activities, homework activities, and she does ironing during the night. She said that she used to go to the toilet 4 times during the night. She felt under depression sleep. She had a lot of anxiety during work, and she referred that she could not stop thinking, that her brain just never relaxed. husband referred that she was not snoring, but she has fragmented sleep. Another tip here that I always tell my patients to come with the spouse, with someone who share the same room, or with someone with the family, for two reasons. First, because sometimes the patient tell one thing and the wife or the husband tell other thing completely different, and they start fighting in front of you, and you keep looking at them. But that's okay. You get two different points of view. And second, because you're going to teach them about sleep. So if the whole family is in your room, that's good. Okay, because each one of them will talk about it to another person. So we will increase the awareness of sleep. So I always tell them, bring whoever you want to. So the husband here was worried. The woman was sad, gaining weight, and had lack of energy. At physiotherapeutic physical examination, I saw that she was overweight and she reported hypertension and hypercholesterolemia. The Epworth sleepiness scale showed that she had sleepiness, but I didn't have to worry about apnea. Ah, I would say, what got your attention? What got my attention was these things. So, she had insomnia and was diagnosed by a gynecologist that was also specialized in sleep medicine. And I had to know what was her total sleep time, total diurnal, sorry about the mistake here, sleep time, how much sleep did she have, what she thought about her sleep quality, if she thought that sleep was refreshing or not, what activities she was doing before sleep, what were her perceptions about sleep, and if she was in use of any medications. My aims were to increase the association between bed and sleep, restore a consistent wakefulness and sleep schedule, restrict time in bed, and now we are going to see it, to increase sleep pressure and, of course, sleep efficiency. I wanted also to reduce somatic or intrusive tensor, that thought, that always mind working that she had. And I wanted to talk to her about the maladaptive beliefs about sleep and maintain good sleep practice. So we started with stimulus control therapy, and I told her, I took here example of something that I never do with my patients, telling them, oh, because you're poor sleep, your central nervous system is inflamed. They go like, oh my God, I have something inside my head. That's not true. So I had to tell her this thing, but in a different way so she could understand. And we tried to reconnect the brain with the bedroom, with the bed, and sleep. I went through all these sleep hygiene things with her. In this case, I remember that I talked about two of the rules, two of these rules on each session. Okay, I just don't give a pamphlet and then okay, you read it and no, they won't get them. So you need to go through each one of them, explain the rationale. But you cannot do it all in one session. There will be too much information. So if you think it's possible, you talk about two or three, or if one is enough, okay, then you have lots of sessions to do that later. Then I got to what I want, the sleep restriction therapy. So if we think that these variables called sleep efficiency is the total sleep time divided by the time in bed multiplied by 100. Then I will get a percentage. And this percentage needs to be above 85%. So having that in mind, this patient went to sleep about 11 o'clock and usually wakes up at 7 o'clock. So this patient had 8 hours in bed, right? This is 50% of sleep efficiency. It's very low. So it's normal that this patient is tired, complaining, sad, and all these symptoms that we saw. I have to increase the sleep efficiency, but how I do it? So the patient is sleeping only 4 hours per night, and I have to increase that. So it's the thing that we talked earlier. If I say you have to be in bed for 8 hours, it's not going to work. So I have to take small steps. And I told her, okay, if you go to bed instead of 11 o'clock at midnight, and if you wake up instead of 7 o'clock at 5 in the morning, in this case particularly, she had to wake up sometimes very early to make breakfast for her family. So I got this idea and said, you will make the breakfast for your family and you have the breakfast with them and you'll be awake. And she was looking at me, oh my God. But see, with this change, it took us few weeks to get this. The sleep efficiency increased from 50% to 80%. The next step then was getting back to this 6 hour of awakening. So she had 5 hours of sleep and the sleep efficiency increased a little bit. The next step, she was going to bed earlier. So she was going to bed around 11 and waking up at 6. And the sleep increased to a normal range. So it takes time. It takes motivation of the patients. It takes motivation of us to see that things happen, but it's possible. Is it clear the sleep restriction therapy? Perfect. And the change of negative thoughts about sleep, relaxing therapies, learning to relax. So all the things that they want to do, like eating healthy, having a hobby, performing relaxing activities, or receiving a massage, that's a dream. Walking the dog. Oh, by the way, I miss my dog too much. And having time with the family, having time for yourself. This is very important. And nowadays, this is uncommon. Well, after 13 months, she walked every day for 30 minutes in the morning. And she went to hydrogymnastics 2 times a week. In the summer, outdoor, because she wanted to get a nice tan. And in the winter, indoor, because Brazil gets a little bit cold. She got new habits in the room. No TV, no clock radio, that one that stays with the lights on all the night long. And she said, oh, my room became cozy. Bedtime and wake-up time, she had consistent schedules of that. And if she wakes up in the middle of the night and she got up, she would do that boring thing that we talked about. And she went to do mindfulness with my friends for 2 times a week. So did all these things resolve her insomnia forever and then she's cured? Of course not. This is a treatment. If she changes her habits, everything will get back from the start. So this is all I had for insomnia for you. I hope you have enjoyed it. Any questions? No? Are you ready for restless leg syndrome? You want to take like a 5 minute break? Yes. So just get up, exercise yourselves a little bit because I see that you are sleepy. And while I change the slides here for restless leg syndrome, and we start all over again. Okay, so now let's talk about restless leg syndrome, RLS. It's also called Willis-Ekbom disease. So it's 10 to 4. I will hardly try to make it to 4:30, but I think I will take some more minutes. Is that okay? If I take like 5 or 10 minutes more? So what is the definition of this disease? Well, this disease is the one that I like the most. I have to tell you that. It's a very difficult disease to treat. And I don't know why, but this is the one that I love to treat. So what is the criteria for the diagnosis? The criteria is the patient must present 4 symptoms that are essential. The first one, they will tell you that there is an urge to move the legs, a necessity to move it, and is usually accompanied or caused by an uncomfortable or an unpleasant sensation. Can someone just shut the door, please? In both legs. This sensation begins, thank you, or worsens during periods of rest or inactivity. These sensations are relieved by movement, partially or totally. And these unpleasant sensations are worse in the evening. So this is the patient that they come to us and they say, I don't have any sleep disturbances, but I feel something in my both legs. When I try to relax or when I try to watch TV before I go to bed, or when I go to bed, I try to sleep, but there's something going on in my legs. There are cramps, an annoying thing, and I have to walk, I have to stretch, I have to do something. And then it gets better. And then I go back to bed and try to sleep again. And then the whole thing starts again. So this is something that disturbs sleep. Okay? The name speaks for itself. Restless legs syndrome. The supportive factor for this criteria is having a positive family history. I have that in my family. The response to treatment is good with dopaminergic medication, and there might be presence of periodic limb movements. We are going to understand this better. So we use this acronym called URBS. This is from the International Restless Leg Syndrome Study Group, which I'm part of. So the U stands for an urge to move one's limbs. It is most frequently in the legs, but can happen in the arms. And we saw once at research a patient who had it in the neck. It was a one case like that. The R stands for rest-induced symptom onset. The G stands for duration. Symptoms improve with movement. And E stands for evening. So there is a circadian pattern with symptoms presence or exacerbation later in the night or during the night. So during the day, the patient says, no, during the day I'm okay. I don't feel anything. Nothing bothers me during the day. But it's just when I go to my bed, something happened. My grandfather used to tell us that when he went to his bed has needles. He said, oh my God, my bed is full of needles. Because he had this unpleasant sensation in his legs. prevalence ranges between 2.1 and 19%. So it's not so common, but as the studies are showing more prevalence of these populations, of these disturbance, as the studies goes on. Again, there is a female predominance of these. RLS may begin in childhood or may begin in adulthood at 40s or 50 years old and increases with age. The ethnic background is a major risk factor. 10% of whites suffer from it, with rates higher than 15% in Northern Europeans and lower in Mediterranean groups. It's usually rare in Asians, so I think you're safe, and even rare in blacks. In Brazil, it's kind of a common thing. So here we have a patient complaining of itchiness, annoying discomfort, sluggishness, freakiness. Sometimes they say it's hot, sometimes they say it's cold. Shaky legs, the legs are moving by themselves like an involuntary movement. A feeling like insects are crawling beneath the skin. Legs move haphazardly. There's a urge to scratch. So that sometimes they say they have pain, but it's not common. The leg, the muscles spasms, and they feel like there is an electrical current, there's something going on over there. The clinical course of RLS can be a chronic persistent RLS, so the symptoms, when not treated, would occur on average at least twice a week in the last year. Or we might have intermittent RLS, that the symptoms will occur more than twice a week in the past year, with the presence of at least 5 lifetime events. So it's something that can be intermittent too. Can be correlated to any bad habits that impact sleep. So here is the first treatment for RLS. Avoid exacerbating factors. Can be a side effect of some antidepressants like fluoxetine or something like that. So if your patient is on serotonin recaptation medication, maybe they have this side effect. And RLS may be together, may happen together with other conditions such as peripheral neuropathy, radiculopathy, iron deficiency, kidney failure, spinal cord conditions, end-stage renal disease, and pregnancy. So be very aware of these populations. If you treat them, they might have RLS. The pathophysiology of this disease is still unclear. This is a big thing because if we don't know how this happens, how we treat it, so this is kind of very difficult thing. We do know that subcortical central nervous, there is a subcortical central nervous system dysfunction, mainly in the dopaminergic pathways, can be one of the mechanisms. And we do know that there is a brain iron deficiency. I'm not talking about systemic iron deficiency that we can see on blood draw. It's inside the brain, something that we cannot measure in humans. So this brain iron deficiency appears with no neurologic change in the dopaminergic neurons. There is studies showing to us that a decreased iron in the substantia nigra and to a lesser extent in other cerebral areas such as the putamen, caudate, and thalamus. There is an impaired iron transport through the blood-brain barrier into the brain, combined with regional neuronal deficiencies. Is it brain? Okay. I thought the word was. And all of this results in hypoxia and myelin loss. So, RLS can be present without systemic iron deficiency. This is an important feature for us to have. So, the explanations and theories that we have for the possible pathophysiological mechanisms of RLS are described in this giant picture. And what we have first is iron deficiency in the brain, iron deficiency. We also can have the contribution of genes that will lead this brain iron deficiency to a hypoadenosinergic state, a hyperglutamatergic state, and a hyperdopaminergic state. These will lead to an activation of the arousal systems, and the patient will have the hyperarousal. And also, we will have a dysfunction of the corticostriatal thalamic cortical circuits that will lead to two features: periodic limb movements of sleep, we are going to talk about that now, and akathisia. Okay? So this is very, very hard to understand, but I think this is the graphic, the figure that puts everything together. But we don't exactly know the mechanisms of what is happening in each one of these systems. The periodic limb movements of, the first thing I want you to know is that periodic limb movements of sleep and restless leg syndrome are different entities. Okay? Restless leg syndrome is clinically diagnosed. PLMS can be a feature of restless leg syndrome. So it's normal to have a patient with RLS that doesn't present anything in the polysomnography. But sometimes we see this channel here. This is a 2-minute sample of polysomnography window showing here the right leg. And what we see is that we have bouts of involuntary movements of this right leg. So this is a periodic limb movement of sleep. And this is correlated with an arousal in the EEG. So every time that we have here the involuntary movement, we have a brief arousal. Okay? So the PLMS, so the periodic limb movements of sleep, can turn to, I'm trying not to complicate, but now things get a little complicated, and I love it. So this PLMS, it can turn to a disease that is called periodic limb movement disorder. that is completely different from RLS. Okay? I'm trying to be the more didactic that I can, because I took a long time to understand this, because no one explained it to me. I had to read it so much. So, in the polysomnography, we will see a characterized periodical recurrent stereotyped limb movements. So we see here the limb movements coming, the pattern repeating, and we can also see the dorsiflexion of the ankle, and sometimes we can see the flexion of the knees and the hip in an interval of 2 to 40 seconds with 0.5 to 10 seconds of duration. And this mostly occur on non-REM sleep. First question: why it occurs in non-REM sleep and not in REM sleep? Yes, perfect. Perfect, you got it. For at least 4 consecutive movements. So the other characteristic is that it occurs most in RLS patients. So PLMD is related to RLS, but they are different diseases. Doesn't have to be correlated to RLS. Can cause daytime sleepiness. Why? Yeah, because it fragments in sleep, and of course, the muscle should be resting and doing the restorative thing that it has to do, and it's not, because it's moving in an involuntary manner. Perfect. And can be a side effect of antidepressants. I already said that. So let's see how it looks like in a polysomnography. This has no sound anyway, so that's okay. See here? He's not moving. This is PLMD. So if I just watch this video, I would say, oh, he might be moving, okay? But how do I know this is PLMD? Because we have all the brain electrodes telling me that this subject is sleeping. I have the electrode placed on right place on the anterior tibialis, and I can see that the muscle is moving and the patient is in which of M3 sleep stage, okay? M3. So these things together is PLMD. Okay. This is how we see in a polysomnography sheet. Let's have a look.
So, wake, REM sleep, and 1 and 2 and M3. And above, you can see the time. Did this patient is left right when he went to bed? No. It took some time. He slept at 1 o'clock. So, let's have a look on that. Because this is not sleep. Okay? We want to see his sleep. So I'll get back to here to use my printer. So what we see here is, you see the green one things here?
We have an arousal here. The patient was in which stage of sleep here? Yes. N3 and N2. Yeah, the N2. And what body position? You see, supine, left side, prone. Perfect. It was turning supine to right, supine to right. And what we see here in purple is the leg movements. And in blue, the periodic limb movements. Here we have the saturation and the heartbeat. It doesn't have to do with saturation, but it has a dysfunction in the autonomic system that is correlated with ILS. Sorry? Okay. So what we see here in blue is the PLM movements happening during all night in and through sleep stage. So this is not a feature that happens only in N3. It happens in N2. It can happen in N1. Okay? So this is how it looks like in a polysomnographic evaluation. Yeah, because one is the index and the other one is just the number of the things that happen. Yeah, and the second one is the index, is the number of the movements per hour of sleep. Okay? So, in restless leg syndrome, what we have is an urgency to move the limb, rest or inactivity precipitates the sensation. The patients have anxiety, despair, distress, in all these symptoms here: colic, irritation, pain, ticking, tiredness, and desire to move. Some patients say that it's hot, some say that it's too cold, but something inside the bones. And in the PLMD, we don't have these complaints. We only have, during sleep, these repetitive spasms or tics, also refreshing, unrefreshing sleep, and sleep fragmentation. So this is to make them very clear to you. The periodic limb movements of sleep may be present in restless leg syndrome patients. They can both occur simultaneously, but they are different diseases, and the absence of RLS is a criteria for diagnosis of PLMD. So this is for you just to know, but the physician is the one who makes the diagnosis and how we treat it. So I think this is the most difficult disorder because as we don't know the mechanism that it happens, we cannot understand how we are going to approach. So what are our objectives, our aims? To alleviate the symptoms, okay? To relieve the symptoms, to decrease their severity, to educate the patient about the disease management, to promote good sleep habits in order to avoid aggravating and exacerbating symptoms, and to improve the sleep quality and, of course, the quality of life. So, we have this behavioral management that is sleep hygiene, avoiding exacerbating factors, sometimes support groups work. This is something that I want to do. I want to have the patients with RLS in my clinic to talk with me and with a psychotherapist about the disease. I'm willing to do that for a long time, and I think this year I will manage it. And nutrition and diet. Sometimes it's very important to refer this patient to a nutritionist. Some of the patients are vegetarian, so they don't get the proper levels of iron that they need. And there is also some research on vitamin B12 that is related somehow to iron, and vegetarians doesn't have because of lack of meat. So what I want to tell you is that there is no non-pharmacological treatment for RILS that will work by itself. It has to be an adjunct therapy with the physician, with medication. So last year, the American Academy of Sleep Medicine launched the latest clinical practice guideline for the treatment of RLS and PLMD, and they suggested the use of something that we know very well, bilateral high-frequency peroneal nerve stimulation, the TENS unit that we use. So this is a conditional recommendation with low certainty of evidence, but this is what we have for now. This is the device called Nidra device. It's from US, a big group over there, and they are commercializing this in there. We don't have that in Brazil until now, but we have the TENS unit in our offices, so we can use that. And these electrodes they are placed here above the fibular nerve, and the studies. So this is something that works for half an hour. The patient ties this up here in both legs, press on, and goes to sleep. It works for half an hour and turns off, and the patient sleeps with this belt tied in their legs. So they claim this is a non-invasive, activate afferent neural pathways because of the release of endorphin, and then acts on inhibition of painful stimuli. So this is a neural response. They have multiple activity at sensory threshold, mimicking signals of voluntary movement. So this is something that I do in my office with the patients. Not Nidra, because I don't have them, but I'll show you pictures in a while. So from these Nidra studies, they reported improvement of 91% in the symptoms of RLS in patients with 8 weeks of treatment. Wow, it's too much. It's 91%. And they have a decrease of 11.3 points in the International Restless Leg Syndrome scale in 32 weeks. This is a huge thing too. So they did that comparing with sham and with baseline. But also, they showed in their sleep that using Nidra device reduced 38% of the sleep disturbances in 32 weeks and increased almost 12 points in 3 days without symptoms of RLS. In this Brazilian consensus that I already spoke about we got this idea. Green is what works for RLS, so neurostimulation and exercise. What we think works, but we have few studies with small sample sizes, but I think these are going to change. So, might use with precaution and do not use, because we don't have evidence, is dry needling and cryotherapy. So, let's have a look in each of them. Regarding exercise, it's very difficult to say which type at what intensity, frequency, and time of the day and the duration of exercise will relieve these symptoms. What we know is that aerobic combined with resistance exercise, when compared to one modality alone, decreases the symptom severity and improves the quality and also the cardiovascular performance. Stretching also helps, and it needs to be from moderate to intense. But here we also have like those U-shaped curves that we saw yesterday. Not having exercise is no good, and having too much exercise also is no good. So the thing is, how much is good? So it varies from patient to patient. We need to test with them and to be with them as long as the treatment occurs. One thing that we know is that it needs to be every day, Saturdays and Sundays included. And at what time of the day do you think it's important for them? We don't know. We don't have this answer. And we don't even know what's the duration of exercise. So this picture here is from a chapter that I wrote for my book about the treatment of Restless, RLS, in a woman. And I said to her this, I gave to her this set of exercise. So she does it every morning, every day, for her entire life. So at first, I showed her one exercise, and we practiced that a week. And then I showed the other one until she learned everything and know how to do it by herself. Okay? There is a meta-analysis showing us the effects of exercise on RLS. And what we see here is that it favors exercise. So this was done in patients in dialysis. They were exercising during the dialysis in a bike, and they also had stretch 3 times a week for about 30 to 45 minutes. And the exercise was effective for these patients on hemodialysis because it improved the severity of RLS. But by which mechanisms, we don't know. Well, this is then the light, the yellow light, okay? So use it with precaution. This is the pneumatic compression. It's just like those ones that the patients have at the hospital. This is the one that I use in my office, but we have to be very, very careful because this patient might have a problem in the legs and cannot wear this. So this study shows here, you can see at baseline, the symptom scores is high, and then after the treatment, 1 month treatment, the symptom score decreased from 24 to 8. So they use 1 hour a day, and they use the compression device 1 hour before going to bed in this investigation. Then this decreased the symptom severity. We don't know in longer periods or if they use in another time during the day would relieve the symptoms. We also have some evidence, and here is a meta-analysis showing evidence that favors acupuncture for ALS. It decreased the severity of the symptoms, but it didn't change the sleep quality of the patient. So be cautious. I don't know here if you can, if you have training, of course, if you can perform acupuncture? No. In Brazil, we can, if we have the training, Chinese training. Other thing that is appearing more and more in literature is the photobiomodulation. So we have the low-level laser therapy, and we also have the infrared light. So there are some devices that we can use them, and there are some studies, you see, from 2010, it's an old one, showing that this infrared light improved symptom severity because it increased tissue perfusion, and therefore the oxynitric generation. That might be a hypothesis in this endothelial dysfunction. So they improve the scores, but we don't know for how long, at what time of the day they can use it. So this is something I would love to investigate. If someone wants, please send me an email. I'll be very happy to collaborate. There is only one study showing that this kind of manual therapy called Mullington improved the symptom severity and also improved sleep quality. So we see here each of these lines is aligned for one patient, and here we see after treatment and here before treatment, contrary, before treatment and then after treatment, and we see that most of them improve. There are other studies combining massage by a device, not by hands, and hot, like this one here is a massage device, and this one here is a massage device combined with vibration. And they also show the same thing. So maybe manual therapies will have, maybe this will be a non-pharmacological approach. Oh, here we go. We have this Guruji that I am very fan of. We have evidence from 2013 that Iyengar yoga specifically, just Iyengar yoga, not other type, can improve the symptoms of RLS. And I'm going to tell you that is why I'm into Iyengar yoga, because I do have RLS. So this improves a lot. I have a good quality of life because of Iyengar yoga that I practice every day. So you see, I'm more Indian than you. There are other possibilities, yes, but we need to investigate more. So there is this device called Hestifik. The device is the strangest thing that I saw in my life, but it helped the patient. And what this is? This is a cushion, and then you put that, you have a gentle pressure in the abductor and the flexor hallux muscles. And this pressure will alleviate the symptoms. How come? We have no idea. But just think about the trajectory of peroneal nerve. There's something going on over there. So I never tried this. I think I could notice it with something giving me pressure in my feet. But this is a non-pharmacological approach that is available in the US. There is also a vibrating platform that you have here. So the hypothesis is the endothelial dysfunction that we just spoke about, and this could lead to increase in blood flux and maybe in nitric oxide. So there are, I think, two investigations showing that there are increased clean blood flux at baseline and immediately after the use of the pentathlon, but it decreases over time. So this, you see, these that I'm talking about is not green or yellow or red. These are possibilities that need to be studied. So these are open venues for research, okay, not for clinical practice. And there is another thing going on that is this hypothesis of a hot dysfunction. This hypothesis claims that RLS patients, I'm getting to an end. This hypothesis claims that RLS patients have an altered perception of heat. So in this thermography picture, what we see are cold feet, and this cold feet is from a control subject, and when inside a room of hot temperature, the variability of cooling varies. The same thing doesn't happen in RLS patients. They have warm feet despite they don't feel it warm. And they have absent cooling of these feet. So it's not only in hot environment, it's only in hot environment. The same thing doesn't happen in cold environment. Maybe this is a reason because it's so common in Brazil, because we also have hot weather there. So this is a mechanical hyperalgesia to pinprick stimuli and develop a central awareness, a dysfunction perception of A fibers, something similar to central sensitization in pain, but quite different. Okay, coming to an end. I know you're all tired, but let's have a look into a case that happened to me a few years ago, or more than a few years ago. This patient is now 79-year-old, but at the time she was 74-year-old female with no non-comorbidities. She was eutrophic, and she had a bilateral meniscectomy 20 years ago. She was referred to me by the geriatrician with a possible diagnosis of neuropathy. She complained about fatigue, diffuse pain, a lot of pain in the lower limbs, but worse at legs. And she was always telling me that she had the feeling that the left leg was always very heavy. So she had primarily nocturnal pain that interfered with her sleep. She has this feeling of heaviness in the lower limbs, loss of functionality, a little bit loss of balance, and stiffening of the lower limbs during nighttime. She denied snoring or other sleep symptoms, didn't nap during the day, and she told me that she never slept well in her whole life. She was also tired, tending to have a depressive mood, irritated about small things, and she said, I thought I was normal. I thought it was part of the aging process. This is something that we hear a lot. No, it's not normal. It's not part of the aging process. And what got my attention was these symptoms. When I saw that, I thought maybe she has RLS. I might send her to the neurologist. But I continued the anamnesis. So she said, she reported that she had about 3.4 hours of sleep each night. She considered that she doesn't sleep because of the pain, the discomfort in her legs. She had trouble initiating sleep and staying asleep. She didn't think she was restored, and she had this annoying feeling. She was on hormone replacement therapy for menopause and trazodone, piaspidine, that was for the cartilage of her knees, and pregabalin. The insomnia severity index was 28, very severe, and the international RLS symptom scales were severe, 30. So I didn't know where to look. Insomnia, RLS, both. I thought about misperception of sleep. I didn't know if her leg was hurting because of the knees or because of other comorbidity. So I needed a doctor with me. And she denied daytime sleepiness, snoring. She was active and she had a routine. So I didn't know what to think. I asked for help, and a friend of mine asked, this is a neurologist, and he asked for a polysomnography. And what we see here, this is perna, this means legs in Brazilian Portuguese. And what we see here is periodic limb movements of sleep, okay? Occurring with arousals that we can see here in these two channels. And then she was referred to a neurologist that is a sleep specialist that was my supervisor, and he asked for blood tests, and everything was normal. And even the iron panel, ferritin, transferrin, the saturation of iron, serum, everything was normal. She was a vegetarian since she was adolescent. The neurologic examination that he performed was without alteration. Everything was okay. And he asked for electroneuromyography that also came within normal parameters. Well, he diagnosed her with RLS and prescribed medication and sent back for physiotherapy. So we had the medical diagnosis. He changed the pregabalin to gabapentin. Sorry about that, forgot to translate. This is iron IV. And sent her to iron IV. There is a treatment. I'm not speaking about it because we cannot do it, but it's important for you just to know that RLS patients often are treated with IV iron. They have like 3 times of iron in the blood. They take it one day, rest for another, take again, rest for another, and take it again. So take it 3 days that you have this iron to try to increase this. For some patients, this helps a lot. For others, it doesn't make a difference. For me, as a patient, helps. I have it once a year. Okay, I go to a hospital and I have it. Prescribed, of course, by my physician. So, what we do with these patients? We have educated them about the disease. We can go through all the sleep hygiene rules and avoid the exacerbating factors, stimulants, sleep routine, and we talk to them about the need for exercise and staying alive. Myofascial release of the lower limbs also helps a lot with the discomfort. And the stretching exercises. This patient, at the time, she did 2 times a week with me, and she was learning the exercises, and she did them at home without me. And she thought it was perfect for her morning routine. Okay, as long as she did it for me anytime. I just wanted her to make exercises every day. And I tried later this Nidra thing that I told you. So the 10 unit. So we started 1 time a week for 45 minutes, varying intensity and frequency. Because now you must know that PANS is good for pain and discomfort only if it changes its parameters during the treatment, because the patients can get used to it, just like opioids. I forgot the name. Tolerance. Accommodation. No, it's not accommodation, it's tolerance. They can become tolerant. So you have to increase each time more and more. So we use a variety in intensity and in frequency, and the devices can do it by themselves. So we don't have to worry about it. So the patient will never become tolerant to that. So I use the electrodes in the fibular nerve below the knee, just like I drew here in this picture. And after 18 months, the International Restless Syndrome Scale severity was from severe to moderate. She was better, but sometimes it still bothers. It happens. It's not the cure, it's a treatment. She said she was sleeping better. She slept for an average 4.5 hours daily without waking up. And I remember that she told me that once she slept for 7 consecutive hours and she was very happy. The strength, the balance, and the performance improved. She exercises every day. At the end of the treatment, we shifted because she got a new job, and she was exercised before going to bed. And this continued for 8 years. The patient now, I still see her. The patient now developed Parkinson's disease. So this is again very common. Restless leg syndrome can be early sign of Parkinson's disease. So she's doing nowadays she's doing neurologic physiotherapy once a week, Pilates twice a week, hydrotherapy twice a week, and doing the exercise by herself. She maintains the medication and the appointments with the doctor, and she sees me sometimes for a coffee. And she has no discharge from the doctor. So this is a real case. I have all the reading material for everything that I presented here for you, and I'll be happy to take any questions. This is a difficult disease to manage. Okay? Thank you very much. You cannot measure it. We don't see it. It's a hypothesis. We see in animal research. In animals, we know that this brain iron deficiency happens. But it's a hypothesis that it also happens in humans. We have no ways to see that in humans. Yeah. We have many of these things that I told you here. We know the possible, and we always say possible because we don't know in humans studies, but we have animal evidence showing that. We have a very strong group in Brazil trying to understand these mechanisms in animals. Great question.
you so much, Christina ma'am, for that incredibly informative session and for discussing clinical cases with us.
Thank you all for your engagement and continued enthusiasm. We will resume tomorrow with more interactive and clinically focused sessions and practical demonstration.
There is an important announcement. The venue for tomorrow's session will be Mir Anis Hall of Dayare Mir Taqi Mir building. The entry is from gate number 15 and the session will start from 9:30 a.m. So please try to be on time. The location is already shared in the group, so you can check the location and come accordingly. Thank you.
And also one more thing, for second half post lunch, the PSG demonstration will be held in two groups.